seen in the experience of your patients. And so then you have a question about it, and then research can answer that question. So that's the first step, is you have to kind of enter the literature with a question. And so there's two types of questions. There's like background questions that essentially ask for kind of general information, like how many people have disc herniations, where do they typically occur at what ages do they occur at. Those kinds of things are kind of background questions. They don't really lend themselves to research. So research is more about foreground questions, right? Where there's a controversy about how something should be managed, or whether two things like disc herniations or structural damage in the back and psychosocial factors interact, but something that's controversial or unclear just on the surface, that's a better foreground question. And so you can see here, that you can see patient and no problem, intervention, diagnosis, comparison, or clinical outcomes. This is this Pico format. So most foreground questions you can be formulated into this Pico format. I would suggest you kind of review this as you study the slides. But this kind of foreground question really evolves as you develop skills and practice. And so this is always kind of a challenge for where you're at now clinically. The foreground questions come from areas of cognitive dissonance. Like if we take Dr. Cuddyford's question, where he recognized that in his mind, he knows that the tendon can take a lot of load because, he's worked with runners and, high-level athletes. So he knows the tendon can be loaded a lot, and yet the current protocols for rehab, we're calling for really low-load exercises. And so there's cognitive dissonance there, meaning that he knows one thing, and then the recommended treatment doesn't really match the body's capabilities, right? And so that's a great foreground question that you're always wondering, geez, if I work them harder, would that be even better for them? Or am I just making the tendinopathy worse, right? So that's a good example of cognitive dissonance. So the best types of research foreground questions come from where there's conflict. And so between what we actually do and what we know. And so what we can do is, as a new person to this, though it's not always easy to come up with those foreground questions, so we're gonna help get you started by looking at what types of questions are typical in terms of practice. And so the first one, and I put these in the perspective of your patients because I thought that might be relevant to you, is if you're making a diagnosis about, say, a disc herniation or a muscle rupture or ligament rupture, the first is, are you sure that the test works? So are they actually correct, and do they give you an accurate diagnosis? Completely fair question. You want to know the answer. Your patient wants to know the answer. In terms of prognosis, this is more interesting because it's like, can you really predict the future? And so your patients might say, what factors are going to be important to my outcome? Okay, and so this is the relative importance of factors versus just generally how long my recovery will take or what kind of limitations might I end up with. And I want you to really let this sink in, that actually for prognosis, what you're looking for is factors that make the outcome different. And so the other piece is not just factors, about like beliefs, but they could also be factors about the physical, impact of the disease. So strokes that have higher severity have less functional recovery long term. Now, therapy asks a little bit different question, which is, hey, if I invest in this treatment, it could be a drug, it could be physical therapy. If I invest, is there a benefit to me that's worth the cost? So in other words, I have this prognosis, but can I actually change that outcome? So for example, we know that beliefs matter for prognosis, but if I tried to do a cognitive behavioral treatment with that person, will that actually alter the outcome? And what's the cost of that? Do I have to come 10 times to treatment to get the benefit, or do I just have to come once and I experience the benefit? And then what's the cost of achieving that? And the cost can be time, or it can be actual money. And the last kind of study that's important for us as PTs is what kinds of outcomes should we measure and use in our clinic? If we're trying to assess our patients, we want to know what their values are and what the validity of those tests are. And so the outcomes, it directly impacts how we develop theory and think about patient care. So those are our 4 buckets, and those are the 4 places where most of your questions are going to come from. What we want to do is start with asking a clinical question. And so the Pico format is where you kind of include each element. So the P stands for patient or problem. The I is an intervention, which would be a therapy question. The type of diagnostic test, which would be a diagnostic test question. And then what prognostic factors you're looking for: severity, patient beliefs, age, obesity, things like that. Those might be prognostic factors that are important to know for a clinical outcome. So the I would get some type of any one of these that you're kind of interested in, and then what you want to compare it to would be the C. So if we had an intervention or therapy that was interesting to us, like exercise, and say the comparison was surgery, so then we would want to compare those two. So that would be the C. In terms of a diagnostic test, you'd have the test here, and then the gold standard would be the C. And then for the prognostic factors, it would be a yes on the prognostic factor or no on the prognostic factor. And so those are that's kind of how the Pico question would work. And then the O is the outcome. And so the reason we start with the Pico format is it gives you a way of structurally knowing what to put in your question as a new person, and it also gives you a way of searching the literature for people who might have done research on a similar question. So let's talk about the O for a minute, because the O kind of helps you categorize a study in terms of whether it's purely theoretical or where it actually is client-centered or has clinical relevance. And so if we look at the ICF model, we noted that really theory-based questions and theory-based studies are going to address the body function and structure level questions. So we know if the outcome of a study is an MRI, for example, or involves kind of strength and range of motion, those are impairment-based things or structural things. So the MRI is structural, range of motion and strength are impairments. So they're really not addressing the patient level problems, which is activities limitations or participations in their life things. So the social roles, work, and play, right? And so essentially, if the outcome of the study or the focus of the study is body functions and structure, well, then it's a theory-based study, and you might not want to read it, unless you know that the impact of those therapies is beneficial to the patient in terms of activities or participation level. Because this is really theory-based information, where this is information that's evaluating the effects of the treatment at the activities or participation levels about the impact of those therapies or diagnostic tests or prognostic factors on something patients find very important to them, which is their functional capacity.